Good evening, everyone. I'll keep my presentation brief. Don't worry. Okay. So I'll be talking about the post-chemotherapy, post-targeted therapy, and post-immunotherapy response assessment on CT scan in lung cancer. So starting with the post-chemotherapy, so we use RECIST 1.1 criteria, which is a morphologic-based criteria for assessing response. So for using RECIST 1.1, the CT scan should be done within 4 weeks before treatment. The slice thickness should be less than or equal to 5 millimeter, and IV contrast is mandatory. So response should be assessed after at least 4 weeks and optimally 6 to 8 weeks. Eggshell plane should be used for measurement, and MRI can be used, but FDG PET CT is complementary. So if there is any discrepancy between the PET CT and CT scan, then you'll have to fall back on the CT scan. Millimeter, lymph nodes of more than equal to 15 millimeter in short axis diameter, they are considered as target lesions. So maximum we can use 2 per organ, and total of 5 target lesions can be used in RECIST 1.1 criteria. And we should make it a point to mention the series and image number in the report. Now coming to non-target lesion, any measurement other than the target lesions are non-target lesions. And of course, pleural effusion, ascites, lymphangitic spread, leptomeningeal disease, bone lesions without a soft tissue component, any non-measurable lesion node, as I already said. Lymph nodes 10 to 15 millimeter in short axis diameter is considered as pathological but non-target, and they need to be mentioned. Now, what is the criteria for progressive disease? So we should always refer to the smallest sum of long axis diameter. If that is compared to the baseline study, then we'll have to compare it with the baseline study. If it is any other smallest diameter while on treatment, then we'll have to compare with that particular scan, and which may not necessarily be the immediate prior scan. So that has to be borne in mind. And of course, the lesion should increase by more than equal to 20%. An absolute increase of at least 5 millimeter is mandatory. Any new lesion, be it measurable or non-measurable, or there is an unequivocal progression of non-target lesions. So all these are considered as progressive disease. Now, if there's a more than equal to 30% decrease in the lesion size, then it's a partial response. If it does not fit into partial response or a progressive disease, a stable disease, and resolution of all the lesions is considered as complete response. Now, addressing the dilemma. So lesions on a follow-up scan at a location which was not scanned at baseline, it should be regarded as a new lesion. Second dilemma is a default value of 5 millimeters should be given if a previously seen target lesion is not visualized on a follow-up scan. You should not give a value of 0. A 5 millimeter default should be given. So even if a short axis diameter of a lymph node falls below 15 millimeter on a follow-up scan, it needs to be measured if it was a target lesion before. And cavitation needs to be documented, although longest diameter you still need to measure based on the RECIST 1.1 criteria. Now, there are certain special scenario. If a lesion coalesces, then definitely the together measurement of the long axis diameter has to be mentioned in the report. Similarly, for lymph nodes, perpendicular to the long axis diameter, that is a short axis diameter maximum, has to be mentioned. So if a lesion fragments out, then individual long axis diameter of the fragment needs to be mentioned. Now for bone lesions, please remember that new onset sclerotic bone lesion suggests response and not a progressive disease. And both lytic as well as sclerotic bone lesions are non-measurable. Only if there's a soft tissue component associated with the lytic bone lesion, and if it is measurable fitting into the criteria by RECIST 1.1, only then you'll have to measure it and consider it as a target. Now, you can see over here that in the prior scan, the bone lesions was not visible. There was no sclerosis or lysis seen in the first scan, in the baseline scan. And on subsequent scan, you can see that new onset sclerotic lesions are visible in the sacrum as well as the ilium. So this suggests response to therapy. Okay. Now coming to post-molecular targeted therapy response assessment, this is a tricky area because RECIST 1.1 is a morphology-based criteria, and every time a size cannot be used for defining response, particularly if you are using targeted therapy, which is a cytostatic agent, unlike the chemotherapy, which is a cytotoxic agent. All right. So in our report, although still we are using RECIST 1.1, we definitely need to document the tumor attenuation value if there's a decrease in the tumor attenuation, and if there's an intratumoral cavitation. All these need to be documented in the report so that they can still continue the treatment and not stop based on the RECIST 1.1. Now, there are proposed alternatives, like we can use a CT tumor volume using the segmentation software, CT tumor perfusion, dual energy CT, diffusion MRI, FTG, PET CT, but no definite criteria or guidelines are still in place. Now, there was one study proposed by Lee using, they proposed a new response criteria using CT based on the presence of cavitation, necrosis, and attenuation changes for response assessment in NSCLC patient who underwent TKI therapy in EGFR positive patients. So generally in lung window, we measure RECIST 1.1 target lesions. All right. So, but then Lee proposed that in a soft tissue window, we only take the solid component and the cavitation part. If the lesion has undergone cavitation in response assessment scan, we subtract that from the cavitation. And then the further measurement is based on the RECIST 1.1. They proposed this. There was a difference from the RECIST 1.1 in the overall survival, but it was not that great to implement it in the day-to-day practice. Now, coming to the last section, that is a post-immunotherapy response assessment. Even here, the situation is tricky because we use iRECIST criteria, definitely immune response evaluation criteria is still there and documented. So why is it tricky? Because post-immunotherapy, there's 5% incidence of pseudo-progression in advanced non-small cell lung cancer. And what is pseudo-progression? That is, there is apparent increase in the tumor burden. The word apparent is very important. It's not a true increase. Apparent increase in the tumor burden after starting immunotherapy because of reactivation of immune cells. And on subsequent scanning, the size of the lesion reduces. So, which implies that it was a pseudo, that is a false progression. So, to account for that, there is iRECIST criteria, which is in place. So, as per that, there is an IUPD, that is unconfirmed disease progression. So, if on a scan we see, a response assessment scan, we see there's a 20% increase in the tumor size from baseline or a new onset target or a non-target lesion, then unconfirmed disease progression should be given in the report. We should not directly label it as progressive disease. If a repeat scan after 4 to 8 weeks shows further progression, more than 5 mm increase in target lesion, new lesions, whether target or non-target. Only then a confirmed progressive disease should be given in the report. Now, if findings remain stable on follow-up scan, then the term IUPD has to be continued till either there's a true progression or a response. And the time, as I already mentioned, the term IUPD is given to account for the pseudo progression so that the ongoing immunotherapeutic drug is continued and not discontinued. Giving you an example over here. So in image A and B, we can see these are the baseline scans. In the right upper lobe, there is a lesion, measurable lesion, and another target lesion in the left lower lobe. So in the response assessment scan, we see, which is C and D, the lesion has increased in size. And there's a substantial increase. So IUPD should be given to this. And then on a further 4 to 6 weeks delayed scan that we see and in E and F, there's a regression of this finding. So this is pseudo progression. Now there's a term called hyperprogression. So if there's a more than twofold increase in the pace of tumor progression after starting immunotherapy, then it is known as hyperprogression and it is associated with worse outcomes. And please remember that pseudoprogression is associated with a good clinical outcome. So clinical condition of the patient is very important in deciding upon the change or line of management. A word about brain metastasis. Now, brain metastasis measured using the RANO-BM criteria. So for this, a contrast enhanced MRI is definitely preferred. The slice thickness should be 5 millimeter or less with 0 millimeter skip. Ideally, it should be less than or equal to 1.5 millimeter. So what is a measurable disease? Any contrast enhancing lesion, which is at least 10 millimeter in longest diameter, visible on at least 2 or more axial slices, and at least 5 millimeter in diameter perpendicular to the longest diameter. And non-measurable, any other measurement which is not fitting into the measurable disease criteria, where borders you cannot reproduce, they're fuzzy borders, dural metastasis, bony metastasis, leptomeningeal disease, or purely cystic non-enhancing lesion. They all are to be considered as non-measurable. And unlike RECIST 1.1, which allows only 2 lesions per organ to be mentioned as a target, in RANO-BM criteria, for brain, 5 target lesions can be mentioned. So this brings me to the end of the talk. Thank you.